Good evening, everyone. Welcome to our research presentation webinar. This is the fifth session, and today's presenter will be Eyob Miteku. He's a BSc in Public Health and MPH Fellow. This is his thesis report, and it's a final research report that he will be presenting today. And our external reviewer will be Dr. Wondosen Amoye. He's an MD, PhD holder. He's an associate professor in internal medicine and infectious disease at the Department of Internal Medicine at Addis Ababa University College of Health Science. He's also honorary full professor in molecular and clinical medicine at the University of Doon, Scotland, and a fellow of Ethiopian Academy of Sciences. I know he doesn't need an introduction. He's one of the very well-known seniors in the field of medicine in the country with a very good reputation as a clinician and as a researcher. There is a lot we can learn from him. We're glad to have you, Dr. Wondosen. Welcome to our webinar. And
thank you.
Thank you. And for the in-house review, I will do the in-house review. My name is Tigist. I am MD MPH and the founder and general manager of Medical Research Lounge. So we will start with the presentation. You will be given 15 to 20 minutes to present. We all invite you to attend attentively and drop your questions anytime in between the webinar, and we will address it at the end of the session. You welcome you too, and you can start presenting. Thank you.
Good evening, everyone. It is Eyob Miteku, and thank you, Dr. Tigist, for giving me this chance. Today here to present my test report. My study title was Survival Rate and its Predictors among Human Immunovirus Patients with Tuberculosis at Addis Clinic in selected public hospital at Addis Ababa, Ethiopia. It's a 6-year hospital-based retrospective cohort study. This is my outline. The introduction part. Tuberculosis is the serious health threat, especially for people using HIV, are more likely than others become sick with TB. It's about 1/3 of the world population is estimated to be infected with tuberculosis, Mycobacterium tuberculosis, and hence at the risk of developing active disease. TB is one of the world's most common cause of death in the era of HIV. As Sustainable Development Goals 7th agenda is to end of the twins epidemic of HIV and tuberculosis by year of 2030. And totally 850,000 estimated HIV-associated TB cases reported in worldwide in 2019, but only 56% were notified. Also, TB is the one of leading cause of people with HIV, but the most frequent opportunistic infections. And also, HIV patient has 50 times chance to develop tuberculosis than HIV negative patients. And let's see the prevalence of HIV TB. Globally account, it is 3.8 to 72.3%. In Africa, 37.4%. In Ethiopia, in 1,000 regions, 3.8%. In Addis Ababa is 22%. So this figure is implication. The tuberculosis infection with HIV is becoming a global emergency, especially in the sub-Saharan Africa country. By the year of 2022, adult patients who were infected with TB and HIV had the median survival period is around 17.6 months worldwide. This justification of study. Ethiopia is also one of the 7th country of the world with high burden with TB, and I don't find any significant study to assess the survival rate, and it is predictors among HIV TB at RT clinic in Addis Ababa. But some of study was done in Ambo, Tabor, and Bardars. According to my review, there is a significant knowledge gap in the field of study. So assessment of the survival rate and the predictors among HIV patient in Addis Ababa is understudied. So the aim of this study is we will assess the measuring the survival time and death status HIV/TB infections. So as Addis Ababa, prevalence of HIV/TB is around 22%. In HIV, the 3.8% secondary to Gambela. So Addis Ababa has high load patients at federal hospitals with unknown survival time, and the mortality rate of the patient is noticed as the gap. And the next part is the significance of study. For this study are the beneficial for reducing of the factor to the community and facility-based HIV care and TB prevention.
Can you hear me, Dr. Yo?
Your mic is mute. Please unmute it and put the slide on a slideshow mode. Please put it on a slideshow mode. And I think if you can increase the volume of your PC from your side, it's better. Most of them are claiming that they're not hearing you very well.
Okay. It's a maximum volume, okay? Okay,
Okay,
now.
put it on a slideshow mode so
Okay.
that they can clearly see the slide.
Okay. So this study provides input and important implication for prevention programs and healthcare professionals. All hospitals under Addis Ababa, hospitals under health centers and regional health bureau and the Ministry of Health. Also for policymakers and governmental organizations, for researchers, and the program efforts towards for improved to HIV control programs, and the results guide the beneficiary on which area focus intervene and strengthens the health systems. Also, the studies serve as used as the baseline data for further studies and related to HIV and TB mortality rate and survival time. Conceptual frameworks and independent variables are categorical as social demographic variable, patient clinical status, and disease-related variables and lifestyle variables listed. And the dependent variables is the survival time measure in week HIV/TB patient from the date of start of anti-TB treatment until the date of death or censored. The research objective, general objective, is to assess the survival rate and its predictors HIV/TB infections patient under ART in select public hospitals. And the specific objective is to determine the survival time to HIV/TB infection patient under ART in select public hospitals. And the second specific objective is to identify the predictor of HIV/TB infection patient under ART clinics. So the next step is the methodology part. The study areas conducted in Addis Ababa, 5 public hospitals. So the 5 public hospitals selected by a simple random sampling technique by using a calorimeter from 12 hospitals. Those hospitals are Milik, St. Paulos, Yekatit, and Zauditu and St. Peter specialized hospitals. And the study period is from May to June. The study design is retrospective course study conducted. The study period is the follow-up period is January 1st, 2016 to January 1st, 2022. Source of population is all HIV/TB infected patients under ART clinic who are follow up in TB treatment from this period. These study populations. The sample size and procedure. For survival analysis is the considering of statistical assumption of the 95% confidence interval. So the power of study is 80% is to detect the hazard ratio of this rate, and the survival distribution and probability event is taken 0.5 by the side, and 20% is non-response rate. This is the formula of survival analysis used for calculation of sample size. So the sample size is 585. The inclusion criteria is all HIV patients with TB conflicted under a clinic who start anti-TB treatment. From this period, the inclusion is incomplete patient medical characters. And the sample procedures, the total number of HIV TB conflicted registered between this period is from 5 hospitals is 2,752. So, and after that, the proportional allocation formula used to address the final sample size to each hospitals, and 585 medical chart is reviewed by or selected by computer generated sample random techniques. The next step is those is independent and dependent variable, and the dichotomous is 0 is if censored and 1 coded as days. The methodology, the operational definition part, censored means generally HIV TB conflicted patients under RT who want to follow up in this period, who will live up until the end of the study and lost, drop out, and transfer out to other clinics and died due to other causes are considered to be censored. There are 3 types of censored: right, left, interval censored are included as censored. And the data collection procedure and quality assurance is data is secondary data, and questionnaires are checklists developed from different literature review, and 5% pretest performed before the exact day of the data collections, and 1 day trainings conducted for data collectors, and collected data was rechecked by personnel investigators. And data was the data management and analysis part. Data was edited and cleaned and coded into SPSS version 24, and data statics and data summary by using of table using frequency and percentage, number of event and center included, and the category health group are checked by Kaplan-Meier curve and median survival time and long rank test. After that, after we check the survival time, and we're going to run off the regression. One is the Cox proportional hazard regression model is applied with considering of 5 assumptions, and the fitness of model of the model for advocacy with the of fitness is test with Schofield residual test. Schofield residual test by checking of the data. It is greater than 0.05 level of significance. And the by ICPSS output, this is try to show the proportional hazard assumption graphical diagnostics as log minus log, and this graph show is one variable, one sex and female and male. Those 2 variables are until 2 groups are passed in roughly and parallelly. So this means is the cost proportion hazard assumption as meet. So this is one of testing of graphic diagnostic by SPSS for. So for 5 assumptions, 5 model assumption plus 1 model advocacy is has meet for my study, and the result in discussion part is the over median survival time is 21 week. That's 95 confidence interval, and 585 TB HIV conflicted patients followed for 72 months. 116 are 19.8% is died, and the remaining 468 were censored. Let's try to interpret. These are 3 examples of Kaplan. This place of residence. Place of residence is one independent variables. So the complementary is a non-parametric used to show the survival experience of categorical group. So as example, this complementary curve show the y-axis is the cumulative probability of surviving from 0% to 100% with the median cut point to 0.5. X-axis is the survival time measure in a week. So let's describe the place of residence at the beginning of study. The survival experience of the patient is similar, but when the time goes after 8 weeks around, who reside in the rural area had the lowest probability of the survival than urban residents. And let's see this example too. Adherence status. 0 is coded as poor adherence and 1 code good adherence. So it is similar to previous. After it's good survival probably to after the beginning of study, but after 6 weeks, patient with good ART and drug adherence have green color curved. Here favorable or survival experienced as compared with poor ART drug adherence at median survival time is 21 week with confidence interval. The third example is the viral load. 0 is undetectable viral load and 1 is high viral load coded. But high viral load client is worse survival chance than the undetectable viral load at the baseline, with the median survival time is 24.8 week with at 95 confidence interval. So the result in discussion part, and those variables are significant predictor with univariate analysis at cut point of less than 0.25%. This is a multivariate box proportional regression species output, and there's 5 variable are is significantly associated with a dependent variable, and let's try to interpret the place of residence as 95 confidence interval as a used of referral of urban as hazard and adjusted hazard ratio shows the patient who live in the rural area were 2.18 times higher probability to death than those who live in the urban area at this p-value. And the type of TB is extrapulmonary TB is used to as a reference, and the patient with pulmonary TB is compared to extrapulmonary was the risk of death with pulmonary TB is by 53% at the p-value. And the adherence of status is poor adherence of ART drug patients as 2.4 times higher chance to mortality than good adherence at this p-value. And the place of residence are significant predictors. The reason is might be due to the rural people lack of the access to TB and service of ensure quick diagnostics and the lack treatment of resource constricted location and physical remoteness and long distance from the health facility. And other low socioeconomic status of the patient and fear of stigma and discrimination, the patient not properly follow their treatment. And the other predictors are WHO clinical stage. This is targeted intervention are needed to focus on the clinical stage monitoring through every follow-up visit during ART refills, and high viral load at the baseline is other predictors. The degree of the active HIV replication of high viral load predicts faster disease progress to AIDS. The type of TB, extrapulmonary form of TB are one predictor. It is most severe than pulmonary TB. It also affects the multi-organ. At the same time, in the case of disseminated tuberculosis, increase the chance of days of the patient who already are weakened by the HIV virus. It needs close follow-up before the disease progress worse by health professional or physicians. And the last predictor factor is adherence status. It's due to those health providers provision adherence counseling level may have different practice and counseling problems that affect the client adherence initially and during follow-up time, which further affect their retention in our users. The limitation strengths of study. The strengths part is, as my knowledge, there is no study conducted in Addis Ababa to assess the survival time in predictor HIV. And the study that was conducted at a large public hospital in Addis Ababa, the study used a long period of time for survival study and fill a gap in research. And this paper are used as the baseline study for further researchers. And the limitation of study is patient record availability was limited, such as INH prophylaxis and family size and smoking and alcohol use status. And the secondary data problems is inaccurate registration, incomplete record, and missed medical chart. As a conclusion, 19.8% of the patient on ART died during the follow-up period within 6 years and 72 months. And the overall median survival time was 21.8 weeks with this confidence interval. As finally, 5 variables are or predictor factors are significantly associated with dependent variable, place of residence, poor adherence to ART, WHO clinical stage, extrapulmonary TB, and high viral load patient, which can equal to predictors of my study. The recommendation part, Minister of Health and Regional Health Bureau, follow ART and anti-TB treatment drug adherence strategic to each provision site, and should develop then design holistic approach and client-centered and target interventions, and should adopt and incorporate WHO guideline. The health centers and healthcare professionals should be recorded patient final treatment outcome, include days, date, and its cause. And TB test must be done for all people living HIV in order to mitigate further deterioration of their health, and strongly follow up for patients who have their high viral load at the baseline, rural area resident client, and WHO clinical stage above 2, and target intervention at the first initiation. And the recommendation for the researchers, prospective cohort study needed to be conducted for the study. It's expensive, but if a study was done by prospective cohort study, the evidence is prospective cohort study better than the retrospective cohort study. So this is my recommendation. And considering people, this lost follow-up become mortality might be underestimated, since the patient lost follow-up to include of individual dying at home without reported. And last, this is my reference. And I'm amplified through appreciate to all medical research lounge members and the family, and deeply grateful to all those who contribute to the success of these papers. And thank you.
Thank you very much, Yo. You have presented it very precisely and clearly. Thank you very much. Now I'll leave the floor for Dr. Wonderson to start the feedback. Dr. Wonderson, over to you.
Thank you, Dr. Tigist. Can you hear me, Mr. Yo?
Yes, we can hear you.
Yeah.
Very good. You know, you selected very important public health issue, which is TB among HIV infected. So I really appreciate your work, but there are certain issues that we need to discuss. So I will start asking you with some basic question. I promise that I limit myself to what you did, what you wrote. Okay, so I would like you to justify what you have mentioned or what you have written. So nothing outside that, okay? With this promise, then I have some basic questions to you. So what's the difference between thesis and dissertation? You.
I can get it.
Did you understand my question?
I didn't get it.
What is the
Okay, I
difference?
didn't get it.
The difference between thesis and dissertation? You said your work is a thesis work. So what's the difference between thesis and dissertation? Okay. Okay, don't worry. Another question I have for you is, what's the difference between rate and ratio?
Ratio and
Rate compared with ratio. What's the difference?
okay.
Rate and ratio. You were mentioning about survival rate. You know, rate. What's the difference between rate and ratio? Is it clear?
Yeah, it's clear.
So what is it? Explain.
Okay. Rate, I try to answer in my research is survival rate. So survival rate is the total days of HIV TB infections put as the rate. Rate is
Rate is per unit time, yeah?
Yeah.
Which one, you know the difference between incidence and prevalence?
Prevalence and incidence.
Incidence versus prevalence. What's the difference?
Incidence is new infections and the prevalence is overall the populations. Already diseased, the incidence is the new infections or new disease. Prevalence is overall of the populations.
There is per unit time. Okay. Rate,
Okay.
whenever you mention rates, there is this per unit time. Okay.
Okay.
Now let's come to your research, actual research. So what was your study design?
Study design. Study design is a method to use for our research.
No, what was your study design? The design of your study.
My design is a retrospective course study.
Okay, very good. So you selected patients who had TB HIV co-infection, yeah?
Yeah.
So with what group did you compare them? The comparison group. Did you have a comparison group?
No, there is no comparison group. It's only
Why?
HIV TB co-infected patient.
Why? Always, having one group alone without another which to compare with. What's the problem?
Okay.
So what group could you have taken to compare the survival?
Yeah, but as comparison group is HIV TB and HIV non-TB infected person, but this in my study is only assess HIV TB infected patient
But
For the last
you
6
compare
years.
to what? You assess their survival compared to what? There is no comparison group.
Yeah.
So that is a serious limitation to me.
Mm.
And you know, in your write-up, you said HIV/TB. Okay, which one is right? HIV/TB or TB/HIV? Is it right to say HIV/TB or TB/HIV? It seems
HIV/TB patient, and I try to assess HIV patient who follow ART treatment in those hospital, but infected HIV tuberculosis co-infected, and they start anti-TB treatment. So HIV/TB co-infections considered.
Always we write first the dominant disease. You know, what makes people sick is TB. So whenever we write, we say TB/HIV. It seems nomenclature, but you know, the write-up now has almost become first we write the dominant disease. Fine. Now let's come to the diagnosis of TB. So the cases whom you selected are patients diagnosed with tuberculosis, yeah? Isn't it?
Okay.
So the cases whom you discussed, in whom you analyzed the survival, were patients with TB, you know, HIV co-infection. And how was the diagnosis of TB made in your study population? First, I would like you to repeat the question if you have understood. How was the diagnosis of TB made in your study population? Is it clear?
This part and the source of population part.
No.
Mm.
My question is, you know, you studied HIV, I mean TB patients, TB/HIV co-infected patients, isn't it? ትክክል አይደለም? ቲቢው እንዴት ነው ዳያግኖስድ የሆነው ነው እኮ ጥያቄው። ኢዮብ አንተ ያጠናሃቸው ሰዎች ላይ ቲቢ እንዴት ነው ዳያግኖስድ የሆነው? በጣም ክሪቲካል ኩዌስችን ነው። ግልጽ ነው?
ያ ግልጽ ነው። ቲቢ ዲቨሎፕ ያደረጉትን ነው የአሪቲ ላይ ያሉት የአሪቲ ላይ ሆነው መድኃኒታቸውን ፎሎ የሚያደርጉት ፔሸንቶች ኤችአይቪ ፔሸንቶች ቲቢ ዲቨሎፕ ያደረጉት እና የአሪቲ ክሊኒክ እንደ ቲቢ ክሊኒክ ላይ ቲቢ ህክምናቸው የሚከታተሉ ማለት ናቸው። በ6 ወር ውስጥ ቲቢ ህክምናቸውን የወሰዱት ምን ያህል ሰርቫይቫል ታይም አላቸው የሚለውን ነው።
ጥሩ ስለ ቲቢ ዳያግኖሲስ ሚንስ ምን ታውቃለህ? ቴል ሚ ሃው ቲቢ ኢዝ ዳያግኖስድ። The diagnostic tools for tuberculosis. First, tell me about pulmonary and then extrapulmonary, because this is important.
Yeah. Okay.
You know, nowadays we say bacteriologically confirmed tuberculosis, meaning it's either smear positive or culture positive or expert positive. You get my point, Eyob? Eyob?
Yeah, culture positive.
Smear positive የሆኑትን ወይም culture positive ወይም expert positive የሆኑትን patienቶች certainly, or in our setting, very likely that they have tuberculosis. So we call these patients bacteriologically confirmed tuberculosis. ምክንያቱም ብዙ diagnosis in hospitals and in health centers presumptive ነው, just based on symptoms and signs without having bacteriologic confirmation. So those patients in whom there is no bacteriologic confirmation, substantial proportion of them do not have TB. It's something else. So now when we discuss tuberculosis, the question that you should address is what percentage of your patients had confirmed tuberculosis? In other words, what percentage of your patients had bacteriologically confirmed tuberculosis? You.
Okay.
Did you get my
Just,
question?
in generally, I try to pick the tuberculosis developed extra and pulmonary TB developed patients on those
በምን
hospitals
አወቀው?
who follow
ፐልመናሪ
their
ቱበርኪሎሲስ
anti-treatment
የሚለውን
specialties.
እነሱ የጻፉትን ነው
Yeah.
ብቻ የወሰድከው? በምን አወቀው ነው
Yeah.
ጥያቄ። ፐልመናሪ ቲቪ መሆኑን በምን አወቀው? እነሱ የጻፉትን ነው አምነህ የተቀበልከው? ቻርቱ ላይ ተጻፈውን?
As a secondary data, ከቻርት ላይ ነው ሪቪው ያደረኩት ፕሉምናሪ እንደ ኤክስትራ ፕሉምናሪ ቲቪ የሚለውን የአሪቲ ካርድ ላይ
ቻርቱ ላይ
ኢንቴክ
እኮ
ተደረጋለሁ።
ስፒከም ሪዛልት ይኖራል፣ ኤክስፐርት ሪዛልት ይኖራል። ያን ማየት ትችል ነበር። እሺ እኔ የሚሻለው ለአንተ ስተዲ ዲዛይን ኔስትድ ኬዝ ኮንትሮል ስተዲ ነው ብዬ ነው ማስበው። ስለ ኔስትድ ኬዝ ኮንትሮል ስተዲ የምታውቀው ነገር አለ?
ያ
ምንድነው ኔስትድ ኬዝ ኮንትሮል ማለት?
in case control already know the outcome and we assess the exposure ማለት ነው።
ኢዮብ ስማ መጀመሪያ ኢዮብ ኔስትድ ኬዝ ኮንትሮል ስተዲ ምን ማለት ነው?
case control
ኖ ኔስት NESTED ኔስትድ ሰምተው አታውቅም ካሁን በፊት? ምክንያቱም እኔ ጥሩ ስለኝ ሁሉም ፔሸንቶች HIV ፖዚቲቭ ናቸው። እዚህ የተወሰኑት ቲቢ ያላቸው እነኚህን ቲቢ ከሌላቸው ጋር ማወዳደር ሁለቱን ነበር ፎሎ ማድረግ ጥሩ። ቲቢ እንግዲህ ዳያግኖስት የሚሆነው ኢኒሻሊ ሊሆን ይችላል and then HIV ዳያግኖስት ይሆናል ኦር መጀመሪያ HIV ዳያግኖስ ተደርጎ ከዛ ቲቢ ዳያግኖስ ሊሆን ይችላል። ስለዚህ ይሄንን መለየት ያስፈልጋል። ኦኬ ሌላ ጥያቄ ያለኝ ላንተ አሁንም የጻፍከው ላይ ነው። አብስትራክቱ ላይ ሃይ ቫይራል ሎድ ምን ማለት ነው? እዩ
ሃይ ቫይራል ሎድ
ምን ማለት ነው?
it is above 1000 copy per ml
ኖ አይደለም።
ሃይ ቫይራል ሎድ
ሃይ ቫይራል ሎድ እኛም ነው above 100,000 በላይ ሲሆን 1000ን ዲቴክተብል እና አሁን ለትሪትመንት WHO ነው ለትሪትመንት ፌሊየር ያንተን ያደረገው እንጂ ክራይቴሪያ ነው እንጂ ሃይ ማለት above 100,000 ነው። እሱ ትክክል አይደለም። እና እንደዚህ ሃይ ደግሞ ቁጥር ሲሆን በሎግ ነው የምታስቀምጠው። ለምሳሌ 100,000 ማለት 3 ሎግ ማለት ነው። ኦኬ ይሄ እንደዛ ሆኖ አብስትራክቱ ላይ ሃይ ቫይራል ሎድ adjusted hazard ratio እስቲ አውጣው። እዚህ ላይ adjusted hazard ratio 0.52 ይላል። ምን ማለት ነው? adjusted hazard ratio 0.52 ማለት ኢንተርፕሬት አድርገው። ኢዮብ
ኦኬ እሺ
አብስትራክት ላይ
let's say ኦኬ
ምን ማለት ነው? adjusted hazard ratio 0.52 ማለት ምን ማለት ነው?
Okay, those is who had the baseline viral load greater than equal to 1000 copy ml is the risk of death by 48% as compared to
ምን ሆነ? ቀነሰ እኮ ነው ኢዮብ። hazard ratio እኮ አንድ በታች ሲሆን ፕሮቴክቲቭ ነው፣ ከዛ በላይ ሲሆን ነው። ስለዚህ እንዲያውም አንተ እኮ እያልከን ያለው ቫይራል ሎዱ above 1000 ሲሆን እንደዚህ ቀንሳል ነው የምትለው። ዛ ፒ ቫልዩ ሲግኒፊካንት ነው አለ። እንደገና ደግሞ WHO ስቴጅ 3 ያልክና P is equal to 0 አለ stage 3 ማለት ቲቪ ማለት ሁሉም ያንተ ፔሸንቶች stage 3 ናቸው at least እና ፒ ቫልዩ 0 ነው አለ ፒ 0 ሊሆን ይችላል እንዴ አሁን እዚህም ጽፈሃል ፒ 0 ሊሆን ይችላል አሁን እዚህ የጻፍከው ስላይድ ፊት ለፊታችን ያለው ስላይድ ላይ ፒ 00 ብለህ ጽፈሃል less than 001 0 አንልም 001 ብለን እንጽፋለን ላይክ አንድ ብለን እንደምንጽፈው 0.9 ምናምን ምክንያቱም always there is a room ግልጽ ነው
ሪቫይዝ አደርገዋለሁ ወይንም
ብዙ የጻፍከው ብዙ ኤዲቶሪያል እንትኖች ያስፈልጉታል ብዙ ግራመር እና ወርድ ፕሮብሌም አለ ጥሩ ነው እሺ አዲስ አበባ ውስጥ አርባን እና ሩራል ትለናለ ምን ማለት ነው የፕሌስ ኦፍ ሬዚደንስ አዲስ አበባ ውስጥ ነው የሰራው አይደል ሩራል አርባን ማለት ነው አዲስ አበባ ውስጥ ሲግለጽን አዲስ አበባ ውስጥ አርባን ሩራል ማለት ነው
ያው ከአዲስ አበባ ውስጥ ያሉትና ከክፍለ ሀገር መጥተው ተከሙትም እነሱ ለመለየት ነው ፕሌስ ኦፍ ሬዚደንስ አልኩት ሞርታሊቲ ኢምፓክት ይኖራል ነው
እሺ
ሩራል ኤሪያ የሚመጡት
የትኞቹ ከተማ ነው ሩራል ያልካቸው አርባን የምትለው የትኛውን ከተማ ነው ሩራል የምትለው የትኛውን ከተማ ነው ለምሳሌ ከሰበታ የሚመጡት ምንድነው
ከአዲስ አበባ ዙሪያ የሚመጡትን እንደ ሩራል ከአዲስ አበባ ዙሪያ ራቅ ያሉት የሚመጡት ስለማለት ከ12 ክፍለ ከተሞች ውጭ የሆኑትን እንደ ሩራል ኮንሲደር አደረኳቸው
ፖለቲካል ኢምፕሊኬሽንም አለው በተጠነቀቅበት ይሄ በጣም አስቸጋሪ ነው እሺ አደረስን ኩልና ጉድ ያልከው በምን ክራይቴሪያ ነው
ሎንግ ዲስታንስ ከፋሲሊቲ ያለው ሎንግ ዲስታንስ ያው አንዱ ኢምፓክት ኮኔ
ሎንግ ዲስታንስ ማለት ነው 1000 ነው 100 ነው ይሄን ዲፋይን ማድረግ ያስፈልጋል ስታዲ ኮ ስትሰራ ስታንዳርድ ዴፊኒሽኖች ካሉ ያንን ወይም ደግሞ አርባን ሩራል የሚለውን የሆነ ስታቲስቲክስ ቢሮ ያወጣው እንትን አለ እሱን መጠቀም ይችላል ግን እዚህ ላይ ሴንስ አይሰጥም አዲስ አበባ ሰርተ
ኦኬ
ዋናው ነገር ቲቪ ላይ CD4 ካውንት ነው ኢምፖርታንት አውትካም ላይ ኒውትሪሽናል ስታተስ ቤዝላይን CD4 ካውንት ኒውትሪሽናል ስታተስ አቸው ይሄን በምን አሰስ አደረክ ለምሳሌ BMI አለ BMIን ኢንቱ አካውንት ወስደሃል CD4 ካውንታቸውን ወስደሃል ቲቪ ነው መጀመሪያ ዳያግኖስ ወይስ HIV ነው ዳያግኖስ የሆነው እነኝን አይታል
እነዚህ ዩኒቨርሲቲ ላይ የነበሩት ቫሪያብሎች ናቸው ግን ቤዝላይን ዌይት ነበር ወሰድኩት ካቴጎሪ ካላሪጎ ቤዝላይን ዌይቶች ወስጃለሁ
ዌይት BMI ለምን አልወሰድ BMI ጻፋል ካርቱ ላይ አለ ቦዲ ማስ
BMI ላይ ጻፋል
ቦዲ ማስ ኢንዴክስ እንዴት ነው ካልኩሌትድ የሚሆነው
አለ ካርድ ላይ
እንዴት ነው ካልኩሌትድ የሚሆነው
ያ
ሌላው ART ስትል እንግዲህ ፈርስት ላይን አለ ሰከንድ ላይን አለ እሱንም ስፔሲፋይ አደረከው የትኛው ART ብቻ ማለቱ ትክክል አይደል ፈርስት ላይን ነው ሰከንድ ላይን ናቸው ኮፒ ልግልጽ አይደለም ሩስ ዳታ አለ ጥሩ ዳታ ሰብስበሃል ይሄንን አጣርተህ ብትሰራው ጥሩ ፔፐር ሊወጣው ይችላል ያስባለሁ ሌላ ጥያቄ ልጠይቅ
እሺ
ኮንፋውንደር እና ባያዝ ልዩነቱ ምንድነው ለምሳሌ ይኸውልህ ለምን እንደጠየኩ ልንገርህ። ሰሌክትድ ሆስፒታል አልክ። እንዴት ነው ሰሌክት ያደረግከው ሆስፒታሎቹን? How did you select these hospitals?
Okay. ሰሌክት ያደረኩት 5 ሆስፒታሎችን ከ12 ሆስፒታሎች ከአዲስ አበባ ውስጥ ካሉ 12 ሆስፒታሎች
በምን ክራይቴሪያ ሰሌክት አደረካቸው?
ሲምፕል ራንደም ቴክኒክ ተጠቅሜ በሎተሪ ሜትር ማለት ነው።
ኦኬ ሲምፕል ራንደም ሳምፕሊንግ ለምን መጠቀም አስፈለገ? ዝም ብለህ ለምን አትወስድም 5 የወደድካቸው? ለምን ሲምፕል ራንደም ሳምፕሊንግ?
30% ያው ሪፕሬዘንታቲቭ ይሆናል አንድን ፖፑሌሽን 30% ለማንሳት ሪፕሬዘንታቲቭ ይሆንልኛል በሚል 4 ሆስፒታሎችን ነው የ12 ሆስፒታል
ዝም ብለህ 4 የምትወዳቸውን ሆስፒታሎች ብትወስድ ምን ችግር አለው? አንተ የምትወዳቸው ጓደኞች ያሉበት ብትወስድ የሚቀርብህ ምን ችግር አለው?
ሳይንቲፊካሊ አይደለም ሰው 12 ሆስፒታሎቹ
በያዝ ምን ማለት ነው? በያዝ ምን ማለት ነው? ኦኬ እነኚህ ነገሮች እንግዲህ እንድታስተውል ነው የምፈልገው። ኦቨርኦል ጥሩ ስራ ነው የሰራው፣ ግን ብታሻሽለው የተሻለ ዳታው አለህ። እኔ የተሻለው ስተዲ ዲዛይን ኔስትድ ኬዝ ኮንትሮል ስተዲ ነው። ኦኬ ኔስትድ ኬዝ ኮንትሮል ማለት ፕሮስፔክቲቭ ኮሆርት ነው፣ ግን ኬዝ እና ኮንትሮል ይኖረዋል። ዩርስ ኢዝ ሬትሮስፔክቲቭ ነው። ሬትሮስፔክቲቭ ኮሆርት ሆኖ ቲቢ ኤችአይቪ እና ኤችአይቪ ዊዛውት ቲቢ ኮንፈርም ቲቢ የሚባለው ላይ እዚህ ላይ እንደ ጥሩ እንዲሆንልህ ኮንፈርምድ ቲቢ ኬዞችን ብትወስድ ጥሩ ነው። ኦኬ እና ሁለቱን አርም ብታወዳድር የተሻለ ነው ብዬ አስባለሁ። ብዙ ኤዲቶሪያል እንትኖች አሉት። ዳታ እንትን ካለ ልንረዳህ ዝግጁ ነን። ኢኒሼቲቭን አፕሪሺየት አደርገዋል። ሪሊ ሃርድ ወርክ ነው። አይ ኖ 5 ሆስፒታልስ ተሯሩጦ መስራት ትልቅ ነገር ነው፣ ከባድ ነው። ቢሆንም ግን የተናገርካቸውን የሰራውን ስራ ጀስቲፋይ ማድረግ መቻል አለበት። የመጨረሻ ጥያቄ ልጠይቅና አቆማለሁ። ሎጂስቲክ ሪግሬሽን እና ኮክስ ፕሮፖርሽናል ሃዛርድ ሪግሬሽን ምንድን ነው ልዩነታቸው?
ኦኬ ኮክስ ሪግሬሽናል ሞዴል ማለት ያው ታይምን ነው ሜጀር የምናደርገው ሰርቫይቫል ታይምን ማለት ነው። ዊዝ 5 ሞዴል ኦፍ አሳምፕሽን ማለት ነው። ሚት ካደረገልን አሁን የሰበሰብነው ዳታ እጃችን ላይ ያለው ዳታ ምንድነው የሚያጠናው የሚለውን አውትካሙን ያለን ሰርቫይቫል ታይም ሜጀር የምናደርግ ከሆነ ኮክስ ነው። 5 አሳምፕሽኖችን ሚት የሚያደርግልን ከሆነ ማለት ነው። ለዛ 5 አሳምፕሽን የምንላቸው ዲፔንደንት ቫሪያብሉ ታይም ሜጀር የሚያደርግ ከሆነ ሎንጊቱዲናል ዳታ ከሆነ እጃችን ላይ ያለው ሎንጊቱዲናል ዳታ ከሆነና ኖ ሌፍት ሴንሰሪንግ የሆነ ሌፍት ሴንሰሪንግ ዳታ ሌፍት ሴንሰሪንግ ኢንክሉድ ያላደረገ ዳታ ካለን እና ቱ መልቲፕሊኬቲቭ ሙቹዋሊ ኤክስክሉሲቭ የሆነ ሴንሰር ዳታ ካለን ለምሳሌ ነምበር ኦፍ ኢቨንት እና ሴንሰር ሆኖ ኮድ መሆን የሚችል ዳታ ካለን እና ደግሞ ለፕሮፖርሽናል አሰምፕሽን ሞዴሉን ደግሞ ሜጀር አድርገን ሞዴል ኦፍ ኤዱኬሽን ሴቱን ራም ማድረግ እንችላለን። ባይናሪ ግን ሎጂስቲክ ሪግሬሽን ሞዴል የምንለው ካቴጎሪካል አውትካም ያለው yes or no ነው። ላይክ የሆነ አሶሲሽን ፋክተር ለአውትካሙ ኤክስፖዠሩ ለአውትካሙ ኢምፓክት ነው ወይ ብለን የምናጠናው ነው ማለት ነው። ኤክስፖዠር ነው የምናጠናው ለአውትካሙ። ስለዚህ አውትካሙን ኮዝ ያደርጋል አያደርግም የሚለው ነገር ነው ባይናሪ ሎጂስቲክ ላይ የምንሰራው። ኮክስ ግን ታይሚንግ ነው ኮንሲደር የሚያደርገው ማን ፌል ያደርጋል።
ጥሩ እንግዲህ ያው ለማስተር ስትሰራ እነኝን ሁሉ ታውቃለህ ብለን ነው የምናስበው። ለዚህ ነው ቤዚክ ነገሮች ቤዚክ ኤፒዲሚዮሎጂ ባዮስታቲስቲክስ ጠይቄሃለሁ እና አንዳንድ ነገሮች ያው ፔፐር እንዴት ይሻሻላል የሚለውን ኮሜንት አድርጌያለሁ። ዶክተር ትዕግስት ከሌሎች የሚነሱት ጥያቄዎች ካሉ ወደ አንቺ መልሼዋለሁ። አመሰግናለሁ።
Thank you very much, Dr. Wandosan. It was a very interesting conversation. This is great. I'm sure Yob and also the audience have learned a lot. This is why I have created the platform to begin with. We usually present our articles, our papers for just public health professionals who are like purely, entirely in the public health profession. But every clinical research has to be assessed from the clinician perspective. There is a lot a public health professional can miss from your article. So you have gained a lot. I am sure take them positively and you can incorporate them. Saying that, I would like to appreciate your effort because as a master's student, I know most of you are studying the program while working and you have family and other issues that you have to take care of and at the same time. So it will leave you very few time to study well and comprehend the materials within a very short time. So this is the beginning of your journey as a researcher and you will improve a lot of things in the future. And one thing that I really appreciated is the fact that you collected data from 5 hospitals, and most of them are not only geographically, but in terms of their administrative structure, completely different. So that must have been a huge burden in terms of logistics, in terms of securing ethical clearance. So this is great because nowadays, these international journals are more geared towards publication of multi-center studies, because that's where we can get a more credible result. Because if you study a single site, that cannot be generalized to a larger setup, and it will always leave a room for other researchers to keep doing other research. And our trend, especially as a master's student, is to stick with one institution where we either work or we're comfortable with going and collecting data with. But you have gone out of your territory and have been everywhere, and this is really something that I appreciate. And the other is, I know most students for a fact avoid survival analysis because it's not something that we routinely see as a master's student. So I know how much people struggle not to do the survival analysis, but I know you took that initiative and you did a lot of job with it. And I want you to appreciate yourself and to give yourself a credit for that. So I have a few comments that I would like to add, in addition to, I share every comments that were raised by Dr. Wandosan. Can you please display the slide on the study period era? Actually, you have improved a lot of things compared to the paper that you have submitted. You have corrected it here, but study period, please. This is something that you know, when we do, I think it's 6 or 7 slide. Okay, it's all right. I think he's good. Okay. So whenever we do follow-up studies, we will have a period, what we call the observational period, and our observation period and our study period will be completely different depending on the nature of the study design. So for Yob's study, I think, okay, let me copy paste it here. On the chat box, you can see that on his study design, he also puts the period during which he has made the observation. So these 5 years period is his observation time and not his study period time, because it's a retrospective study. The study period, or what we also refer to as the data collection period, is the time during which he collects the data. That is actually 2 or 3 months in the present time. But he had to go back and review the charts for the past 5 years. So the period from January 1st, 2016 to January 1st, 2020 is his observation period. And I want you all, if there's someone who's not familiar with these things, I want you to go and refer what study period is and what observation period is. And for his study, this is observation period. The other is something that I agree with Dr. Wandosan. Whenever you say cohort study design or case control design, we expect there to be comparator groups. So in a cohort study design, there should be exposed and non-exposed groups. at the beginning of your study. And for a case control, there should be cases and controls at the beginning of the study. That's what differentiates these comparative study designs from others. But in a cohort design, there are two things. When we're dealing with retrospective data, we may differ from classifying the groups based on their exposure status, and we might dive into just taking everyone, enrolling everyone who fulfill the eligibility criteria and follow them. In that case, we call it a retrospective chart review study design. And this is a very well-known study design, commonly used. You can also call it retrospective record review, because when we say chart, it might refer to the manually collected charts, but even in a EMR system, we call it retrospective record review. So this is a very well-known study design. It means that you have followed a group of patients for a while, but you do not classify them into exposed and non-exposed groups. On the other hand, if it was like a prospective study, a prospective cohort study, sometimes we might follow a group of patients without classifying them into exposed and non-exposed groups. For example, my personal experience, while I was working as a principal investigator for the COVID-19 research at Millennium COVID-19 Center, we were interested in studying every patient who presented to the center. So this is one big cohort of patients, like group of patients that we have been following without classifying them into groups. So in such cases, we call it a prospective observational study design. This is also a very well-known design. So if it's not a cohort, we have to say it's a prospective observational. If it's a retrospective data and we do not classify the patients, then we have to say it's a retrospective chart review. So I think we can rename it as retrospective chart review. And for the population, I think source study population, target population, study units, these are things that we all should have, should understand very well, because they are like, one is the subset of the other. So when you have your source population, you mentioned that these are all TB HIV co-infected patients who are on ART and on follow-up at the hospitals. So your study population will be those that are selected from these population groups. They're not different in terms of their diagnosis, in terms of their other eligibility criteria. So please try to make sure that these things have a flow and one is the subgroup of the other. And any new form of, I don't know, condition or medical treatment or other factors should be introduced while you are going down from the target population to your study population. And with regard to eligibility criteria, you have stated that patients with incomplete medical chart are excluded, but this is not acceptable. If you started like by enrolling everyone during the study period and you do not calculate a sample size, that can be an acceptable exclusion criteria. But in this case, you have calculated sample size. So that means whenever you encounter a chart which is not, which has missed variables, then that will be considered as a chart loss, or in a primary data collection, what we call non-response. So I think I always mention these things, eligibility criteria. Most people confuse them. And I suggest you to go back and read about it. With regard to sample size determination, every research should have, the sample size calculation should be determined based on the study design and the nature of the study population. So for survival analysis, there are two things. If you did a retrospective cohort or prospective observational design, that means one big group without classification, then the sample size calculation method that you use is different. If you have two groups, the sample size calculation, the formula that you use is going to be completely different. So in this case, you correctly use the one that is fit for one survival group of patients, but there are a lot of things missing in it. The sample size calculation formula is completely different, not like a cohort design or a case control. It has its own procedures. I was expecting to see all those. You did not present those. I think you should consider that. And since you have selected only 5 hospitals from the 13, you should consider design effect in your calculation, but you did not show us that. And as for the operational definition, I was hoping to see smoking and drinking like defined, but they were not presented. And also adherence is not well clarified. So you should work on those things, because we expect our articles to be read by even a layman. So someone with TB or HIV might be interested in reading your article. So when they read it, they want to understand what does it mean? When do you say someone is a smoker? How do you define that? The same works for alcohol drinking, so you should consider that. With regard to censoring, you have said a few things, but I think let me talk about that together with the result. So the outcome of his study, let me get back to the audience. What was the outcome of his study? Please write it on the chat box. Let me give you 30 minutes, and please tell us what was the outcome of his study, or the dependent variable of his study.
Okay.
No,
The outcome
the
of-
question is for the audience, not for you. Okay.
Okay.
I want you to write the questions, and if there's anything that you like to reflect at the end, you can. So, okay. So normally in any other studies, our ultimate goal is measuring the outcome itself, like death or being alive, complicated, not complicated, and all other like yes, no, all other binary outcomes, or it can be multinomial, ordinal, doesn't matter, but we're interested in the outcome itself, mild, moderate, severe, and other things. But in survival analysis, what we are interested is in measuring the time that it takes for the patients to achieve the outcome, not the outcome itself. So what we're doing here is we're assessing the time to event. Survival analysis is also called time to event analysis, because what we're measuring is not if the patient died or not. The major interest is how long does it take for an RVI patient to die if they're infected with HIV, if they're co-infected with TB. So we're interested in that days. So it's like when we have cases, cancer cases, we say your median survival time is like this. You have 6 months, 2 years, and stuff like that, right? So that's the survival time. We're measuring the time from the occurrence of something. It could be the diagnosis of a cancer or the diagnosis of tuberculosis, up to the time the patient achieves that event, and that event could be the days. Or we can alternatively measure recovery. We can measure the time from surgery up to developing complication, and anything. The end output can be anything. So what's important is we're measuring the time and not just outcome. So when we measure the time to the outcome, what makes survival analysis special is if we encounter patients who are, the potential outcomes are the patient either dies or still is alive, or the patient could end up being lost to follow-up. So in survival analysis, there is a room to accommodate all other potential outcomes. So that's why we call it time to event or censoring. So censoring means those who did not achieve the event. Our event is death. So if the patient didn't die, or if the patient is lost to follow-up, or if the patient is transferred to another facility, or if our study ends without the patient dying, then we call all those things censored observations. So we are measuring the time to event or censoring. So normally survival time, patients join our study and leave our study at different times. So the proper measure, the summary measure is median survival time. So that's why he was presenting like 23, 24 weeks and others. So it should be presented that way. The other is if we want to measure the death, just for the sake of reporting, then Dr. Wandosan was also mentioning it, that it's important to know the difference between incidence and prevalence. So these are both rates, right? So these are both rates. So incidence rate and prevalence rate. Which one is the proper thing to calculate in a follow-up data? So in a cohort data, which one is the proper thing to calculate? Is it incidence rate or prevalence rate? Back to the audience. Let me give you 30 seconds and please write down your answer. For his study, it's a follow-up study, it's a cohort data. Which one is the proper thing to calculate? So Prevalence is basically, it tells us the burden of a problem. That means we're going to go into some community or a hospital setup, and we just measure the number of cases with the outcome, and we divide that by the total population. So that means we're getting how many disease cases are there within that population. So we don't know whether it's a new case, an old case, and we have no idea. So what it can tell us is the burden of that disease condition within the community. But when we talk about incidence, we're talking about the risk of a given condition. That means if we had a community with no, for example, if we're assessing the burden or the risk of HIV, if we have a community who are like entirely HIV negative, over a period of time, 6 years, 1 month, or 2 years, how many new infections will we encounter? So that's number of new infections divided by those who are at risk of developing the infection will give us the incidence. So incidence measures the risk of developing a disease, and it will tell us how risky is a given disease condition, but prevalence tells us the burden of a given condition, both old and new cases. So incidence is something that we calculate in a follow-up data. You'll have like completely like an unaffected population, for example, during COVID. So we have no cases at the beginning. So over a period of time, we have new infections. So over the at-risk population, we divide that, and then we'll get the incidence rate. So you should calculate incidence rates as to measure the days. But I think I'm afraid this is an example, by the way, Mikhail, I'm just giving an example. If we have a community with no HIV, so in his case, yes, his study population is TB HIV co-infected population, and what we're measuring is the death. So at the beginning, none of them are like dead, right? If there is a death case, we don't even enroll that. We call it statistically left-censored observation. That means the patient is already dead by the time we start the study. So we're not interested in that patient. Rather, we're interested for among those who are alive at the beginning of the study, how many of them died at the end. And we consider the time of days in the calculation of incidence rate. So yes, thank you, Kabrisfo. Thank you. Okay, so if you guys are interested, there are 2 types of incidence. The first one is cumulative incidence. Cumulative incidence is when the follow-up duration is like the same for all the participants. We call it a cumulative incidence, and there is no difference in time. This is usually not the case in clinical practice, because it's rather something that works in a mini event. Let's say, for example, in some occasion, a number of people attend an event and they dine together, and within few hours, some of them got sick due to some, I don't know, some bacterial infection or something from what they have dined. So in that period, since all of them are in the same room for the same period of time for a few hours, we can call it a cumulative incidence or something like that. But in real life, people enter into our study and leave our study at different times, and their observation period will differ. So when their observation period is different, we have to calculate what we call incidence density. So incidence density, you also should have calculated incidence density. So at the end of the day, our denominator is not the number of population, right? Instead, it's the percent time observation that we have made. So if we have observed like these many people over a period of, let's say, 2 years or 3 years percent time observation, then the risk of death is this much. So I think if you guys are interested, on the MRL YouTube channel, we have a very detailed video on the prevalence and incidence calculation with demonstration of example using a clinical case. So you can read about that. Thank you, Kabrisfov, for adding that. So that should be calculated. It's very important. The other thing is on data management. It's like I am a fan of data management, and when I see a data that's not well managed, I get pissed, honestly, because it's very important to calculate our data. Let me write you something. Let's say, for example, the adjusted hazard ratio is 4.5, and the 95% confidence interval is, okay, I'm sorry, confidence interval is 2.6 up to 345. Please see this number and tell me if you're comfortable with this. Let's say this is a result from, if you see this result on a published article, what do you feel? Are you comfortable? You wouldn't have any question? For precision, right? So it's like telling our patient that his risk of death is like 4.5 times higher than some other patient who doesn't have a similar risk, but it ranges from 2.6 times up to 345.7 times. We don't expect our result to be this far wide, right? There's always a margin of error. There's an interval for our results because we're studying a sample, not an entire population. So we can never tell the exact result. So that's why we present our results with 95% confidence interval, with interquartile range, with a standard deviation to show that there's a boundary. So it has to be precise. If you see a result like this, the problem is an issue of data management. So if we have small frequencies in one group, we have to be able to merge it with the other. And if merging is not possible, then we have to drop that variable from the regression analysis because it will give us something like this, which is unrealistic, and it will disturb the entire regression model and with its result. So for his study, age less than 14 years and family size of above 5 have very few participants in it, and they should have them merged for a better result. And on the Cox regression, Dr. Wonderson addressed it very well, but there is a very important thing that I want to mention. When we have like multiple response groups, for example, for WHO stage, he said that he has like stage 1 to 3, and he compared them with stage 4. And the result is we have only one significant result for stage 3. Stage 1 and 2 are not significant. So let me save us a trouble. And the meaning is like stage 3. Patients in stage 3 have better survival chance compared to those at stage 4. So, well, this is something that we expect, right? We're okay with it, definitely. But it says that for stage 1 and 2, there is no significant relationship. There is no significant difference. The adjusted hazard ratio crosses 1. So are you comfortable with this result? I mean, stage 3 is better than stage 4. Yes, of course. They will have less risk of death, but it says stage 1 and 2 are the same. So when you compare the 4 groups, it's saying that the stage 3 is better, but being at stage 1 and 2 and 4 are the same, right? Does it give like sense considering the clinical part of the condition? I'm also trying to show you another thing. There are some contradictory things like this. So whenever we have, this is especially very notable when you have multiple response categories. When you get a positive result for one category, you should be able to see, you know, our problem is when we have a significant result, we just interpret that and leave the rest. So some of the non-significant results will also tell us a lot, and it even tells us whether it's the right decision to accept the results or not. The other is the balance between statistical and clinical relevance is very important, because on his Kaplan-Meier plots, when he compares the groups, there were significant results for some of the groups. For example, for, I don't know, viral load, like 22 versus 23 weeks between the 2 groups, high and low viral load. So this is statistically significant. But is it clinically, I mean, that much significant? I think his battery just died and he couldn't display it. So since this is a session is recorded, you'll be able to see it on the video. So when we get statistical significance is a very important thing, because that's where we're going to start the conversation. But after we see the statistically significant result, we have to contextualize it into the clinical meaning. So if it doesn't mean anything clinically, the result that we get, I mean, is it very alarming, 22 and 23 weeks? Sometimes even with 1 day or 2 days difference, the statistics can give you a significant result. But you have to ask as a clinician, does it make sense? I mean, is that very alarming? Do I do something with this result? Am I going to amend the guideline because of this result? So if we're not going to make that kind of decision based on the statistically significant result, then we have to reconsider. But what I'm saying is not do not accept the statistical significant result, but accept that result. But we should be able to tell the audience, our readers, that this result, despite its statistical significance, is not that much clinically meaningful and doesn't bring in any change in the practice, right? So it should be presented that way. The other is, since Yob's battery died, I'd like to say just a few things. Please avoid using the word multivariate. I honestly have tried, over the past 4 years as a public health professional, I have tried my best to tell everyone to avoid the confusion between these two terms, but I just keep seeing it happening like here and there. So which one is the proper term? Back to the audience, is multivariate analysis or multivariable analysis the proper term? Multivariable, right? So multivariable analysis means in your regression model, you have a number of multiple independent variables. Multivariate analysis means in your regression analysis, you have more than one dependent variable. We don't have more than one dependent or outcome variable. We have multiple independent variables. So the proper term is multivariable analysis. The other is in his presentation, he was talking about hazard ratio, right? So just to refresh your memory, if we are doing cross-sectional or case control study design, the proper measure of association is odds ratio, right? So if we're doing cohort study, and if the outcome, cohort or experimental study, and if the outcome is, if we're interested in measuring the outcome itself, like how many died, how many survived, or how many complicated, how many did not complicate, and instead of the time to the outcome, if we're just measuring the outcome, and if the study design is cohort or experimental study design, the proper measure of association is relative risk. If our study design is cohort and experimental, and if the outcome is time to event, here there are two things that I want you to remember. If the outcome is, to talk about survival analysis to begin with, the study has to be a follow-up study. Without a follow-up study, you can't have survival analysis because we're measuring time to outcome. So back to the question, in a cohort or experimental study, if the outcome is time to event or time to the outcome, then the proper measure of association is hazard ratio. So whenever you see hazard ratio, then automatically it's a follow-up study with a survival analysis, time to event outcome. Great. So on his the limitation, he mentioned that mortality might be underestimated since patient lost to follow-up, stuff like that. So in this study, we're not interested about the number of days, how many days are there. We're not interested in that. We are rather interested in the time, the median survival time. How long does the patient survive after the co-infection? So survival analysis, in addition to measuring the time, the most important thing is it considers censoring in its model. As long as our censored observations are not very like high proportion, it's okay, because it will consider the censored observations in the model, and it will give us an acceptable result. So by the way, one thing, if you have never run a survival analysis, if your censored observation is very high proportion, then the model will itself fail and it will not run the model itself, because your event has to be large and relatively your censored observation has to be few. So let's say 70–80% are like dead, but the rest are censored, then that is acceptable. The model will also run. And if I don't know, I'm asking myself this question, what is the cutoff point? I honestly don't know that, but the model itself will figure it out and will say you can't run the analysis because the censored observation is very, very large. So make sure that your event is always to an acceptable level. His recommendations are not totally result driven. Make sure that your recommendations are result driven. Again, I don't know, since he can't display the recommendation, every recommendation has to be given based on the result that we have obtained. not based on our knowledge of the problem from our reading or from our previous interactions or from our personal opinion. Rather, it should depend on our results, and which results? The incidence, the survival time, the median survival time, the incidence rate that we have found, and the significant associated factors that we have obtained. So based on these significant results, what do you recommend the clinician to do? What do you recommend hospitals to do? What do you recommend policy and decision makers to do? So always make sure that your results are result driven. So I think what I expect is for you to take all the comments and suggestions that are forwarded so far and work on them, because as a first draft thesis report, this is really amazing, because we all know what we have been through to get to where we get today. So I really appreciate his courage and his commitment. I hope you'll incorporate all the comments and revise his draft accordingly. So I have been, Dr. Wenderson was also collecting your questions. I don't believe there are different questions that are listed here, and since he's not here, we'd rather skip that part, but I invite you guys to drop your questions because we will forward it to him later. He will consider it after the session. So Dr. Wenderson, if you have anything to add.
Yeah, in fact, you know, I learned several points from your discussion and from the paper too. Okay, so whenever you read papers, you learn something. And my point is, you know, there are lots of rooms whereby he can improve the quality of the paper as long as he has the data. And he has to really work on the data. Some of it doesn't really make sense, you know, he has to really work. And I think, you know, with all these comments and some hard work, I hope he will have a very good paper. That's what I would like to say.
Thank you.
I enjoyed the exercise. Yeah.
Thank you very much. He would definitely. The most important thing is to learn from the gaps that you or other people made, so that you can improve your article better. My colleagues usually ask me, where did you learn these things? And I always claim that I have learned these things because I attend thesis defense. I don't like the word defense because it seems very stressful. So that's why I call it thesis presentation, by the way. So that's why I try to bring this platform, because people invite me to talk about research methods, statistics, and others. Unless you see it practiced, you will never have like a clear picture of where it falls when it comes to a real article writing. So it will give you a good opportunity, since it is going to be available online on our YouTube channel. You can see it. By the way, since he's not here, let me respond to some of the questions. Where is the model fitness test? For Cox regression model, if you are using spaces, you can do graphical residual tests using graphs, and you see if they are parallel to each other for the Cox proportional hazard model. That's why he did. But if you have stata, there is an objective test. I am personally a fan of objective statistical tests, because it will clearly tell you whether it's fit or not based on the p-value. So there's what we call a global test for the Cox proportional hazard model assumption. But since he used spaces, he presented the graphical result at the beginning of his study, his presentation on the data management plan. I think you guys can keep dropping the questions. Dr. Wenderson, you can drop them the post-test. Dr. Wenderson, our CPD coordinator, is also Dr. Wenderson. So I'd like to thank Dr. Wenderson for your I mean, I did not expect these money insights from the paper. You have forwarded a lot of educational comments that we all appreciated. If you have any message for these young researchers, let me give you the chance, and we will excuse you to leave the session, because it will be on for a while.
Okay, I would like to join you. In fact, you know, these are the kind of sessions where one can learn. Learning is a process which has no end. And the more you learn, the more you come to realize that, you don't know. Actually, you really don't know. So whenever I read papers, what I learn is I really don't know. So always I learn from my ignorance, from my mistakes. And, I really appreciate such a large group, and with Dr. Tigist enthusiasm. And I promise that I will join you. And I really appreciate, it's, all the exercise that we went through. Thank you. Have a good night.
Thank you very much. You two have a great night. Thank you.